thinking or anything like that. So if anyone's got any questions, just save them for the end. There's plenty of time for questions at the end anyway. But let's say I'll be completely blind at that point, so I'll just share my window.
I'll be your eyes and ears, Chris, in the chat and on the questions for you, so no worries.
There we go. So there we go. I've got it all set up. Perfect. Right. So before I get into the practical part of the session, I just wanted to set out what I think today is about. So I know many of you have already seen the joint health and wellbeing strategy and Marmot Place update that I've done. So I'm not going to repeat too much of that in too much detail. But the purpose of this session is more about what Marmot means for local authority, health and care partnership, NHS VCSE, just the system as a whole, and where we might start applying those principles in practice. So it's not just a programme update, it's more of a sort of so what conversation. So what does Marmot Place mean for the HCP, NHS VCSE sector and local authority, and the work we're already doing across prevention, neighbourhoods, long-term conditions, children and families, workforce and community support? My aim is to give that background, ground the conversation, and then move quickly into sort of practical application. So just to give you a quick timeline of sort of the journey of becoming a Marmot Place. So initially there was the DPH report for 2023 that was around the wider inequalities in health, and I've got some of the authors in the room here today, which really started the ball rolling in conversations around health inequalities in North East Lincolnshire. Then Cabinet approval for becoming a Marmot Place was secured in 2025. In December of 2025, the Joint Health and Wellbeing Strategy for the next 10 years was approved by full council, which gives us a long-term vision for health and wellbeing across the borough. In February 2026, contracts were signed with UCL's Institute of Health Equity, and now we're in the governance phase of that work, and that includes developing the terms of reference, inviting the advisory group and steering group arrangements, so the programme has the right leadership, challenge and partnership oversight. Alongside that, our local insights team have been working with UCL to develop a local data pack, which will be really important because Marmot has to be grounded in local evidence, where those inequalities are greatest, which communities are most affected, and where the system has the greatest opportunity to act. Marmot's also been built into council reporting, so there's now a Marmot section included in all council reports going forward, and that matters because it's that system level lever, because it starts to move Marmot from being a standalone piece of public health conversation into something that influences wider decision making. The public launch is currently being planned for early October. It was initially going to be, we tried to get it in before the summer holidays, but it just wasn't going to happen with Michael Marmot's diary is jam-packed, he's all over the place, so early October is looking like the most likely date. But the important point for today is that we don't need to wait until that launch or until every part of the governance is fully mature before we start thinking about what Marmot Place can mean for our work. And the way I'd summarise it overall is that the Joint Health and Wellbeing Strategy, if you haven't read it, is the general vision for the borough, and Marmot Place is the practical framework to take that vision and make it into a reality, particularly by narrowing inequalities and acting on the wider determinants of health. So today is less about giving another update on process and more about asking, what does Marmot Place mean for the system as a whole and the work we're already doing. So before we move into what Marmot means for the system, I think it's worth grounding it in what is Marmot Place. It's talked about like it's a brand, it's a policy brand, or it's a local government initiative, and it's just assumed that people know what it is and what it looks like. But it's rooted in decades of epidemiological evidence around health inequalities and the social determinants of health. And that goes all the way back to with Michael Marmot's work starting in the 70s through into the 1980s with his Whitehall studies, which looks at British civil servants. And what was powerful about that research was that it showed differences in health outcomes across employment grades. So even among people who were all working in the same sort of system and were working, we're experiencing different levels of health inequalities. So the key insight was that health inequalities are not only about the poorest communities having worse health than the richest. It follows that gradient. So the people in the middle of the gradient have got it slightly worse than those above them, and so on and so forth. So in simple terms, as social and economic position changes, health changes with it, and each step down the ladder, people are more likely to experience poorer health outcomes. And this matters because it changes the way we think about prevention and health inequalities. It moves us from asking only what illness does someone have or what individual behaviours are contributing to risk. Those questions still matter. Smoking, physical activity, poor diet, high blood pressure, and alcohol, they all matter. But Marmot asks us to go one step further with it and ask why those risks are more common in some communities than others. And Michael Marmot puts it in a way which I think it's really simple, really easy way of looking at it, but he likes to look at the causes of the causes. So we're not only asking whether someone smokes, we're asking what stress, housing conditions, income, employment, environment, social norms influence and sit behind the behaviour choices that people make. We're not only asking whether someone is physically inactive, we're asking whether they have safe places to be active, affordable opportunities, time, confidence, transport, childcare, social support, and a local environment that makes movement realistic. We're not only asking whether someone attends a health appointment, we're asking whether, the way we design those services assumes that the people have the literacy, confidence, digital access, flexibility, trust, and resources to engage with that. And those are sort of foundational, core of the Marmot approach. It asks us to think about the conditions in which people are born, grow, learn, work, live, and age, and how these conditions shape health long before someone arrives in a clinical service or in one of our services. And this really matters for the system because we really need to look at the outcomes we're trying to improve. We're all trying to improve the same things: cardiovascular disease, diabetes, respiratory illness, mental health, healthy aging, and children's outcomes. But they're all patterned by this social gradient. And that's why we've got the two graphs on the screen there, which demonstrate the social gradient perfectly. So the top one is death by cardiovascular disease, sorted by ward in North East Lincolnshire. Furthest left being the most deprived, furthest right being the most affluent, and you can see it forms that perfect gradient. So that's where, and I think you said it really well, Amy, when we talk about wards, they do bleed into each other. So, you could look at this graph and you could see that, Freshney might sit somewhere that you wouldn't expect, but there's a pocket of Freshney, the Willows, which may sit higher on the gradient. So that's one of the big sort of takeaways we've had from our work with UCL so far, is that the data, we need to start looking in a smaller areas than ward data because it's missing clusters of people that we really need to work with. And to show that this is across the life course, the graph at the bottom is sorted into, rather than deciles, into thirds, most deprived to least deprived. And that's childhood overweight and obesity in North East Lincolnshire. So again, you see that same perfect gradient going from higher rates to lower rates. So you can apply this, there's so many different measurements and metrics that the social gradient would apply to. So, when we talk about Marmot principles, we're not talking about a loose set of values. We're talking about an evidence-based framework for acting on wider conditions that shape health. And that brings us to the local call to action in North East Lincolnshire, and that's healthy life expectancy. Healthy life expectancy in Lincolnshire is now around 54 years, and over that last decade, that's fallen from around 62 years, which is it's a stark figure. It means that, not only it's not only about how long people are living, because that's tended to have plateaued a little bit. So people are living the same amount of time, but they're now living more time in poorer health. So this is a self-reported metric. So it is, you can query it because it is self-reported, but the people in North East Lincolnshire are feeling they're not healthy at this point. So you can't really ignore that data. So this isn't just a public health concern, it's a system-wide concern. Marmot asks us to go further than just describing that problem. It asks us to look at what is really driving people into poorer health so early. Is it poverty, poor housing, insecure work, low income, food insecurity, poor transport? Digital, the list is endless. It's probably a combination of all of them. Or is it as well that the services that we do already have available, are they harder to access in practice for people with the greater need? So if our residents are becoming unwell at 54, prevention can't be a side issue. It has to be central to how we work. And that's why I'd frame healthy life expectancy as a real call to action, and Marmot as a framework for acting on that. The challenge for us is not only to treat people well once they're unwell, it's to work together on the conditions that mean some residents become unwell much earlier in the first place. So if the social gradient explains that pattern and healthy life expectancy shows us what that pattern means locally, the Marmot principles will give us that framework for responding to that data. So these are the 8 Marmot principles. They're principles or domains. They're sort of interchangeable terms that they use for them. I don't want to go into each one in huge detail, but it's worth translating them into what they might look like on a system level. So the first being giving every child the best start in life. That includes maternity, early years, family support, speech and language, school readiness, and the wider conditions that children grow up in. The second, enabling children, young people, and adults to maximise their capabilities and have control over their lives. For the system, that links closely with personalised care. A lot of Michael Marmot's epidemiological work focuses around a lack of autonomy and a lack of control, and that leading to a lot of the stresses that cause that earlier healthy life expectancy drop. So they found that the people with less money and less say-so in what their working patterns look like and the control in their lives, they were the ones that tended to show, worse health outcomes. So for this one, I really see, personalized care, social prescribing, community power, patient voice, supporting people on a community level and working with them in realistic ways that they want to work with, rather than making people conform to a system that we want them to fit to. How can we make the system fit them? The third, fair employment and good work. And this matters in the room right now. We've probably got some of the biggest employers in North East Lincolnshire anyway. But as well as the work that we've got going on in the in the sort of manual and manufacturing sectors we've got in the area. It's one of the major determinants of health. But it's not just whether someone has a job; it's whether that work is secure, fairly paid, safe, meaningful, and compatible with good health. Are we forcing VCSE organisations that we work to? Are we forcing them into a funding pattern year by year, and people into roles with poor job security? I think there's scope for us all organisations to look at what we're doing to better improve people's working security internally and from commissioned services externally. The fourth is ensuring a healthy standard of living for all, and that links directly to poverty, income, debt, fuel poverty, food insecurity, and whether people have enough resource to live a healthy life. The fifth is creating healthy and sustainable places and communities, and that includes housing, transport, green space, air quality, community safety, social connection, and whether local places make health easier or harder to engage with. The sixth is strengthening the role of and impact of ill health prevention. And this is where a lot of the public health work that we do, NHS work that we do, and VCSE and health and care partnership work connects very directly. We've got NHS Health Checks, hypertension screening, smoking cessation, healthy weight, healthy lifestyle, physical activity, vaccinations, early diagnosis. All of that leads into this piece. The seventh is tackling racism, discrimination and their outcomes. This means that recognising some communities face additional barriers, poorer access, poorer experience, and worse outcomes because of discrimination and exclusion. The 2024 DPH report went into this. And again, when we talk about stark, not even healthy life expectancy, but stark life expectancy data, especially around Gypsy Roma traveller, homelessness, Their life expectancy is in the 50s for some of those populations. So, it's a how can we reach those kind of people? The eighth is pursuing environmental sustainability and health equity together. And that's about recognizing that climate, transport, housing, air quality, and sustainability are also health equity issues. And sitting underneath all of this is the key Marmot delivery principle, which is proportionate universalism. And that means that services should be available universally, but with a scale and intensity that's proportionate to need. So in other words, we don't abandon universal services, but we recognise that the same offer for everyone will not necessarily produce fair outcomes because people are not starting from the same place. And that principle becomes really important when we start thinking about NHS health checks, physical activity, prevention, neighbourhood health, social prescribing, and the wider priorities that we've got in our area. So I wanted to talk about some learning from Coventry, and I promise I've got 4 more slides, so I'm not going to be, it won't be a 1-hour monologue, I promise. So I wanted to talk about Coventry, which was the first Marmot city. They started their journey in 2013 with this. There's a real recognition that every Marmot city, Marmot Place are individual. So there's Coventry, there's a lot of evaluation and we can draw a lot of learning from them, but the geography, at North East Lincolnshire, we can't just copy Coventry. We're a different place. We've got different geography, different assets, different challenges, different industries. The value of Coventry is that it shows what using the Marmot framework, when it's treated as a long-term way of working rather than a short-term public health programme, what it can do. One of the most interesting points from the Coventry evaluation is that becoming a Marmot city for them didn't come with a new pot of money. There was no additional dedicated funding stream for them, and there was no ready-made template for what a Marmot Place city looked like. So they had to build the approach through existing relationships, existing programs, and pulling those system levers across the city. And I think that's quite reassuring for us as a place because I think that's something we already do very well in North East Lincolnshire. I think we already do work well as a place. We already have good relationships as a place. So I think from the conversations we've had with UCL, we're starting ahead of a lot of other places that they've worked with previously, because we are a slightly more mature system than they've seen when they've gone into other places. So I think it's reassuring and is a real point for optimism. Their evaluation highlights from Coventry highlight that they were able to create, through committing to Marmot, it was a strategic commitment which gave partners and everyone in the system a shared language, and it helped generate consensus in the direction that they were pulling towards. And it gave it gave everyone the leverage to ask, what does this decision do for health equity? What impact is this going to have on policies, commissioning, service design, where services are located? The second thing I think is important from Coventry is that Marmot became a partnership approach, not just a public health project. Their 10-year reflection describes that the Marmot approach has been embedded into the Coventry health and wellbeing strategy. So the timing of our health and wellbeing strategy has fallen at a really, really good time because it aligns very much so with Marmot Place, with the building blocks of health that are in that. And for North East Lincolnshire, I think it's exactly where we need to position this, that we've got that new joint health and wellbeing strategy for the borough. And Marmot Place is just one of the practical frameworks that makes that vision into reality, particularly around reducing inequalities and acting on those wider determinants of health. The Coventry reflection, it describes Marmot as a philosophy, a way of thinking and collaborating so that processes and services are designed to reduce inequalities. And what Marmot Place, I think, does really well, it balances idealism and pragmatism. Sometimes, you can have a framework to work with that feels very idealistic and you're sort of going, well, how can I make that into a reality? But Marmot Place really gives you that lens and that tool to turn it into a reality. So it does strike that really fine balance between pragmatism and idealism. So I think the question's more about, how do we use the work that we're already doing rather than creating new work? How do we reduce the impact on the social gradient and narrow the gap between the people on the wrong end of the health inequalities instead of unintentionally widening it? And I've picked an arbitrary example for this later on that I'll go into. So Coventry and relevance for NHS and partnership working. So from their standpoint, I thought this would be a useful conversation point. So from their report, they had Dr. Sarah Rystrick, who sits as both a Marmot Partnership co-chair and the ICB Marmot champion. And she talked about being able to deliver from a medical lens, and that Marmot allowed her to sort of broaden her horizons through the partnership and through linking primary care, carers, community work. They have a thing called the job shop there and family hubs. And there's a quote in that report where she says that an inhaler or a tablet might be useful, but so are sustainable transport links and warmer housing, which I think from someone working within the NHS, I think sometimes when you're at the coalface a lot in healthcare, having previously worked in healthcare, it's hard to lift your head up and look at that wider system. And I think, the way the advisory board and steering groups and the way the discussions are going to take place as part of Marmot Place, it will allow those clinicians time to get away from the coalface and look at the wider system-wide challenges and how they can be a part of it rather than almost being forced to be a part of that reactive side of healthcare. So I think that's a really strong message for this, community of practice. It's really relevant to all of us, really. How we can take a step back, even when we're working, day to day, potentially in healthcare settings. A lot of the outcomes we're trying to improve, like I said earlier, they're all very similar. But the vast majority of them are influenced by what happens before someone reaches a clinical service and what support exists after that contact. Coventry gives us a useful example of how broad a Marmot partnership can become. So in their 10-year reflection, they describe how partners from the council, ICB, NHS trusts, universities, voluntary sector, advice services, DWP, employment skills, transport planning, migration, climate change, and others were all at the table, all had their voices heard. And I just think it shows that Marmot isn't just a public health pet project. It really is much broader than that. But there was also words of caution from Coventry. Because Marmot is a whole system approach, it's very difficult to attribute population level outcomes directly to being a Marmot Place. So there's almost an element of trusting the process and buying into that and recognizing that, this isn't about creating single programs that can work as interventions. We're not looking at simple cause and effect because the system we're working in is so complex. But if we're looking at the work we do through Marmot lenses, the 8 domains, and making sure the work is accounting for all of those different domains, the work you'll be doing will be addressing health inequalities. And because Coventry are in a much more mature system, they're now reaping the benefits of that. But it means we need to measure the right things. So we're not just measuring the amount of activity, but whether our work is reaching the right people in the right places and whether it's narrowing or widening inequalities. Are we putting system level changes in place that means wider determinants are more considered? And even if we're just doing that, down the line, that will improve health inequalities. So Marmot needs to become a shared way of working, not just a public health owned project. We don't need to wait for all that governance to be fully mature before we start applying the lens. We can start, with work streams that are existent now. And the real test is probably in our already universal services and prevention offers. How are they being delivered? Are they proportionate? And that's one of the examples I'm going to use today. So bringing it back to North East Lincolnshire, what does Marmot actually mean, for HCP, NHS, VCSE, all our partners. You know, the first thing to say is Marmot's not asking organisations to invent, like I said earlier, completely separate new streams of work, because I feel like, and that would be the quickest way to lose people, to go into organisations and say, this is the new way we're working, you will conform, you will fit to it. We see how that doesn't work with the people we're trying to reach. That also, as a behaviour change, wouldn't work for the other organisations. So, most of us, we're all under pressure. We're all working as hard as we can. There's already, a huge amount happening, in terms of prevention, neighbourhoods, children and families, long-term conditions, workforce and community support. For me, the value of Marmot is that it gives us a shared lens for looking at that existing work differently, especially in that healthcare setting, about getting that system alignment. And that's where I think neighbourhood health is a really exciting, way of working forwards. And I'm really keen to see how that progresses. It helps us ask whether our collective work is actually pulling in the same direction on prevention inequalities. So when we talk about neighbourhood health, social prescribing, long-term conditions, inclusion health, workforce, children and young people, or community-based care, Marmot gives us a way of asking, are these things all connected? Is that one person 10 different challenges? So why don't we just wrap around that one person and fix those 10 challenges, rather than expecting 10 different services to potentially do that, or flagging that up to 10 different services so they don't have to recruit, as it's not as challenging to recruit those people then. Because a lot of health inequalities are created in the spaces that sit between services. So someone might have a clinical risk identified, but then not get the follow-up. They might be advised to be more physically active, but then not have a realistic or affordable offer locally to them. They might be signposted to support, but not have the confidence, transport, language, and digital access to take the next step. So Marmot asks us to look at that whole pathway and not just individual services. I keep coming back to healthcare because it feels like an easy one to look at, but you look at the changes we've had to, my background's in physiotherapy, so I'll defer to that. In terms of people seeking, MSK, musculoskeletal physiotherapy, is one of the biggest challenges people are facing, in terms of osteoarthritis and, different conditions that are impacting the musculoskeletal system. Historically, that all used to be based at, either at Princess Diana Hospital, which isn't ideal for people to get to. It's very challenging for some people to get to. How do people get there if they're working Monday to Friday, 9 to 5? It's very, the changes are happening. It is now more in the community, and we are heading in that direction, which is all the better. So yeah, I think Marmot really, really gives us that lens to start looking at our work with that, that sort of lens much more, and I think we can really start to look at our community groups and VCSE sector more, and not asking more of them. But as part of Marmot work, they recognise the VCSE sector and community organisations are they're the assets. We really need to think of them as, the first point of call of, if we want to work with that community, how can we work with those existing assets that are in those places? So that might be, a community centre, an advice service, food project, carers group, sports club. They might not describe themselves as health interventions, but we almost, through empowering those organisations and wrapping ourselves into those organisations, we can almost make them health organisations to increase that health equity work in the borough. So in a Marmot approach, the VCSE sector is not just an engagement route. It's not just a place where we go when, we want to reach people. It's part of that core infrastructure, and we need to help them be as mature and robust and strong as possible. We need to be careful about how we approach the VCSE sector with this. We need to be thinking about their capacity, their funding, their sustainability, growing those smaller organisations, and what we can do to better, empower that. Are we designing our work in a way that narrows the gap, or are we simply just increasing activity? And that's a really important distinction. You know, we could increase the number of people receiving a prevention offer, but if most of that increase comes from people who are already healthier, more affluent, or already engaged in services, then we may improve the overall numbers while leaving inequalities unchanged or even making the gap wider. So the Marmot question is not only how many people did we reach, but, you know, who did we reach? Who did we miss? Who followed through? And who actually benefited? And that's, you know, I'm going to go into it in the next couple of slides, you know, make it slightly more tangible. I've used NHS Health Checks just as an example, but like the blood pressure screening work that we're also doing, you know, falls foul, you know, the same challenges. You know, this links directly to prevention, cardiovascular disease. You know, that's the leading cause of mortality in North East Lincolnshire and England. So, you know, it's a real key part of where our life expectancy and where potentially our healthy life expectancy is, you know, cardiovascular disease. So NHS Health Checks, for anyone who doesn't know, are a universal, you know, prevention offer for people eligible age 40 to 74, designed to help identify different conditions such as heart disease, stroke, kidney disease, diabetes, and dementia. You know, so on the face of it, when you think about that prevention Marmot principle, perfect. You know, it's exactly what we want. You know, it's upstream, it's risk-based, you know, it's got the potential to identify people before serious illness can develop. But the Marmot question is not just whether that offer exists, it's, you know, who's invited, who's attending, who is receiving those follow-up and who is actually benefiting. And this is where the distinction between a universal offer and an equitable offer becomes really important. You know, and we design our services, you know, that they're universal in design, but they're unequal in practice. So the people most likely to attend an NHS health check are those already more health literate, more confident navigating services, more digitally connected, more able to take time off work and already engaged with primary care. So we might be increasing activity and we'll be patting ourselves on the back without necessarily reducing those health inequalities. And in the worst case, we risk actually making healthy people healthier while people with the greatest cardiovascular risk exist completely outside of the pathway. You know, and this isn't a criticism of NHS health checks or anyone individually or anything like that. It's just a design challenge for all universal prevention programs. You know, the question's whether we're delivering the offer in a way that is proportionate to need. So rather than only asking how many health checks have we delivered, a Marmot approach would be to ask, are we reaching people in the most deprived wards? Are we reaching people who are not routinely engaging in primary care? Are we reaching people in lower paid, insecure or shift-based work? You know, how do we reach those people? How do we help them attend appointments? Are we reaching carers, parents, people with severe mental illness, people with learning disabilities, migrant communities, the digitally excluded, people with lower trust in statutory services? You know, and are we looking beyond attendance essentially? You know, that list could go on and on and on. Because the health check itself as well is only the start of the pathway. You know, you might have that first meeting with the GP or practice nurse that's doing it. But if someone's found to have high blood pressure or high cholesterol, diabetes risk, you know, what next? Do they attend? Do they go to a GP follow-up? Do they understand what they've been told? Do they have support to act on it? I appreciate I'm just asking an endless amount of rhetorical questions, but that's what's really useful about the Marmot lens. It asks those uncomfortable questions where, you know, you sit back and go, I'm doing great work. I'm doing really, really impactful work. But once you go down that rabbit hole of, are we actually reaching the right people? Sometimes you take that step back and you go, well, actually, there's real room for improvement. And that's where, you know, Marmot becomes a very practical lens in that prevention pathway. And it doesn't just become a point of contact. So I shared this with Amy earlier in another meeting around the blood pressure work we're doing. And it's a cascade of care that I've put together on the right for the community level blood pressure screening that we've done. And I think it summarizes it perfectly that we're losing a lot of people in different places. And it's how do we then get those people back into the system and making sure we're being very targeted and very deliberate. So by creating this cascade of care here, I was very proud of the work, and I still am very proud of the work that we've done for Know Your Numbers Week and the community screening that we've done. But at the tail end of it, the referral outcome was not captured, linkage to care unknown. And that for me is my goal now, is how we can make that linkage to care known, how we can get that 274 people that we've screened back into the blue, back engaging into the system, into statutory services, being diagnosed and controlled. So yeah, it's sort of, it's taking that work, and I think this community screening is a perfect example of taking a passive invitation and turning it into active outreach. You know, letters, text, digital booking systems, they work for some people, but they don't work equally for everyone. And the Marmot approach would ask whether we need to take the offer into workplaces, community settings, trusted VCSE spaces, food banks, family hubs, carers groups and sports clubs, housing settings, or, you know, the priority wards and areas. You know, the second shift is moving from that equal offer to that proportionate offer. You know, everyone's eligible. They can still be offered, you know, a health check, a blood pressure screen, but the intensity of that engagement should be greater where the risks and the barriers are greater. And that's at the core of that proportionate universalism in practice, in the offer. And the third shift is moving from a completed check to a completed pathway, and closing those feedback loops. You know, and the success measure should not only be how many checks are completed, it's whether people identified at risk are supported into the next step and what that next step looks like for them, and whether it's realistic for their lives. You know, and this does link directly to work we're already doing locally. You know, it shows that the challenge that detection's not enough unless we can close that loop in diagnosis, treatment and control, because we might just have another 274 people walking around North East Lincolnshire knowing that they've potentially got hypertension. You know, they've got this symptomless leading cause of cardiovascular disease, but then the system doesn't work for them to actively engage with sorting that problem. So it's I thought I'd sort of wind it down. So where do we think we should start applying this lens if we were going to sort of shine that lens on something now with focus? You know, that's the conversation I really want to take away from this, and give you guys a bit of time if you want to feed back in. You know, what priorities have we got in the system that, you know, we need to look at, that, you know, the way they're designed, you know, how we can change that. What's happening with neighbourhood health with regards to that, social prescribing, children and families. You know, which current work streams have we got that could reduce health inequalities if we design them more deliberately? You know, where are the universal offers that we're currently doing that you think are at risk of widening the gap? You know, what data do we need? Because we can go back to UCL, and, you know, what data do we need to understand, to see who is reached, you know, who is missed, who is benefits? Because part of this Marmot Place work, we've got access to, you know, the academics at UCL, and that, you know, that sort of higher level kind of research out of place lens that they can give us with the experience they've got from the other places that they're working in as well. You know, healthy life expectancy, it's given us the call to action. Marmot Place has given us the framework for that action. You know, the opportunity for everyone in this room, the system, is to use that framework on work that they're already doing, that's already in front of us, so that prevention, access and outcomes can be more equitable. And I'd like to throw it out to the room, you know, if you've got any questions or any piece of work, you know, you feel that the kind of input is needed. Yeah, let's talk. Now's an opportunity to talk about it. So thank you for your time and listening to me ramble on.
Chris, just before you open up the chat, I'm just going to say thank you ever so much. I'm going to stop recording because we're going to talk about local work streams, but that was brilliant. Thank you very much. I'll be quiet and I'm just going to stop recording while you do that. Otherwise, I have to edit